গম পাই যাব লাইভ ষ্ট্ৰিমিং হৈ গ'লে দেই
Okay, so good evening everyone, all NEBOI members. So we are here with a lapse of one classroom because of Eid. So this is our 10th NEBOI classroom. Welcome you all. So first of all, I request Dr. Shubhamoy Chakraborty to please introduce our expert, Dr. Gautam Khaun. Dr. Shubhamoy, please.
Thank you, madam. And good evening, all. Today, our expert of NEBOI classroom is Dr. Gautam Khaun. His present position, Chief ENT Consultant at Nightingale Hospital, Guwahati. Head of the Department of ENT, Pratisha Hospital, Guwahati. Consultant ENT Surgeon, Apollo International Hospital, Guwahati. As for educational qualification, he did HSLC from Central School, Guwahati in 1979, pre-university from St. Edmund's College, Shillong in 1982, MBBS from Guwahati Medical College in 1987, MSc/ENT from Guwahati Medical College in 1992. He received many awards, including S. Kumar Award in 1992 at Kohima, Swami Vivekananda Award in NEBOICon in 1997 held in Nagaon, L.H. Hiranandani Award won Best Paper for ENT Specialist in 2001 in Dibrugarh, delivered S.N. Sarmah oration at Tawang in NEBOICon in 2010, delivered Dr. Shatiban Rai Memorial Oration in 2017 in West Bengal, delivered Dr. K.K. Agarwal Lecture Annual Conference of Rajasthan Branch of AOI in April 2024. He was the editor of Annual Journal of Northeastern Branch of AOI for 5 years, was treasurer in NEBOI for 2 years. He has been the treasurer in Guwahati Pain Palliative Society since foundation 1999, former treasurer Association of Neurosurgeons of India, former honorary secretary Association of Neurosurgeons of India, President Association of Neurosurgeons of India 2026 to 28, member of Court of the Guwahati University 2014 to 2016. He is the founder president of Northeast Sleep Society, founder president of NEIWGWES, that is Northeast India Working Group of Endoscopic Ear Surgeon 2016 to 2020, founder president of Dhani, member of Governors Board of Indian Academy of Otolaryngology and Head and Neck Surgery, IOHNS, president of IOHNS from 2021-22, honorary fellow of IOHNS 2023, was an executive body member All India Radiology Society, one of the founder of Pratidhani, secretary of Santanir, a home for the elderly from 2023. He is managing the trustee of GVSV Foundation. He was felicitated by the Economic Times of Doctors Day as one of the inspiring ENT doctors of India in 2021, felicitated by the Biotrikram Group, conducted live surgical workshop at microscopic ear surgery and face at various places, delivered number of invited talks, free papers, participated in panel discussion in various conferences. He has got more than 20 publications in his account. He is authored chapter of Meniere's disease, differential diagnosis and management in ECAB clinical update booklet in common vestibular disorder, authored chapter of principle of laryngeal framework surgery in the textbook of laryngology, authored chapter in a textbook of vertigo and dizziness, a case-based study edited by Dr. Ambar Chakraborty, co-authored of 2 handbooks, pediatric airway and cochlear implant surgery, reviewer of 3 index journals, has published a number of public interest articles in various newspapers and magazines. He has spoken regularly in various ENT-related subjects in radio and TV. His interest popularizing the teaching is phonosurgery, microear surgery, airway, and vertigo management. His hobbies: traveling, photography, painting, music. Sir, I welcome you. Thank you very much to give some time in NEBOI classroom. Thank you very much, sir. We are honored.
Thank you, Dr. Shubhamoy, for the introduction of Dr. Gautam Khaun. So our today's speaker is Dr. Manish Kumar Singh. So may I request Dr. Anjana to introduce Dr. Manish Kumar Singh. Dr. Anjana, please.
Thank you, Sujeva. It's a great honor to introduce Dr. Manish Kumar Singh. He is a well-known ENT surgeon. He's from Dibrugarh. His name needs no introduction at this present. But I need to read few of lines about him. He is a DLO from Guwahati Medical College, and he did his fellowship in endoscopic sinus surgery and salvage surgery under Dr. T.N. Jankiram in Trichy. So he's a very good ENT endoscopic sinus surgeon and salvage surgeon. So presently he is working as a consultant in ENT department in Brahmaputta Hospital, Dibrugarh. So with that, I welcome Dr. Manish to deliver his lecture.
Thank you, sir.
Thank you, Dr. Anjan, for introducing Dr. Manish so beautifully. So today's moderators are Dr. Nibaran Sharma. Manish, ek minute. Dr. Nibaran Sharma and Dr. Kipamoy Nath. So may I request Dr. Hiranyo Baido to introduce Dr. Nibaran Sharma and Dr. Kipamoy Nath.
Okay. I welcome Dr. Nibaran Sharma as moderator for today's session. So about Nibaran Sharma, he passed his MS from Assam Medical College and Hospital, Dibrugarh in 1998, and he did MBBS same from Assam Medical College and Hospital, Dibrugarh in 1988. Now he is a ENT consultant, United Hospital, Nalbari, since 2004 till date. And he providing comprehensive ENT consultation, surgical care and management of ENT disorders. He was a consultant, ENT consultant in NMB Borua Nursing Home, Nalbari, since 1998 to 2003. And he was a medical and health officer 1 in Nalbari since 1992 to 1994. And he was a junior and senior resident in All India Hospital, Duliajan from 1990 to 1992. And professional association, he was a secretary in Indian Medical Association, IMA Nalbari branch from 2012 to 2017. I welcome. He has areas of expertise in general ENT practice, ear disorder and hearing problem, nasal and sinus disorders, throat and voice disorders, head and neck conditions, ENT surgical procedures. So I welcome Dr. Nibaran Sharma as today's moderator. And next I welcome Dr. Kipamoy Nath. Dr. Kipamoy Nath, presently he is working as associate professor in the Department of ENT, Silchar Medical College. He did his Bachelor in Medicine and Surgery, MBBS, from Assam University, Silchar, and he did Master Degree in ENT from Assam University, Silchar. About his membership, so he is a member from different organizations like Association of Otolaryngologists of India, Foundation for Head and Neck Oncology, Indian Society of Otology, All India Rhinology Society, Northeastern Branch of Otolaryngologists, Northeast India Working Group of Endoscopic Ear Surgeons, Indian Medical Association, Association of Otolaryngologists of Silchar, and National Medicos Organization. His professional experience, presently working as associate professor in the Department of ENT, Silchar Medical College, and he was an associate professor Department of ENT, Lakhimpur Medical College, and he was assistant professor in the Department of Otolaryngology, Silchar Medical College from 2016 to 2020. So he has 12 publications in his account, and his thesis subject was study of squamous cell carcinoma of larynx and laryngopharynx and its management. And he has many presentations, 5 or 6 presentations, and he has achievement and recognition from many certificate course like allergic rhinitis instructional course, hand-on training course in RhinoCon 2023, and EdCom Communications, and certificate participation in Curriculum Implementation Support Program 2 in 2020. So I welcome another in his account, he received distinction in Professional Diploma in Photography from Shaw Academy in June 2020. I welcome Dr. Kripamoy.
Thank you, madam. Thank you, madam. Thank you.
Thank you, Renu Madam, for beautiful introduction. So may I request Dr. Manish to start his presentation? Your time is 30 minutes. And may I request everyone to mute their mic? Thank you.
Sure.
Hello. Hello. Can everybody hear me? Hello.
Yes, you are audible.
Yes, you are audible. Yes. Go ahead.
Audible.
Yeah. First of all, a very warm evening to everybody present here. And thanks for taking your time out of your busy schedule. In fact, it's a big honor for me to speak in front of stalwarts like Khan sir here, Sarmah sir here, Dr. Pratama sir, and all my teachers. And it's amazing that everybody is taking their busy schedule off for this thing. I hope I can fulfill what is expected. Uh, so I haven't, and I'm really so honored that I'm talking about something which I love. In fact, I love doing endoscopic sinus surgery over the last decade or so, and I'll be talking more about the principles of endoscopic sinus surgery, what I have been doing recently, what has changed for last 10 years, and maybe not sure if I can go into the thing how I do it, but at least why I do it, why I operate on these patients. So we'll be discussing more on that. And if time permits, we can go into the procedures also. So I'm Dr. Manish Singh. I work in Brahmputra Hospital, and I'll be talking about the principles of endoscopic sinus surgery as of date in 2026. So why are we talking about this? Because it's a huge problem statement, and we see a lot of patients suffering from rhinosinusitis, rhinitis, CRS with polyposis, without polyposis, different spectrum of diseases involving the upper airway. So it's a devastating disease, not always life-threatening, but still a lot of money goes into the taking care of these patients, and the surgery involved is pretty expensive. In fact, almost 4.5% of US healthcare expense goes into this. And each surgery in maybe US, it costs more than $10,000, sometimes even more. And beyond it, and almost in 1/4 of the patients, the surgery is so-called to be failed. Not necessarily it has failed, but the disease process is such. As we go ahead, we might try to understand more about it. So definition of chronic rhinosinusitis is chronic rhinosinusitis, with or without polyposis, is defined as presence of 2 or more symptoms, one of which should either be nasal blockage or obstruction, congestion, or discharge, maybe anterior or posterior nasal drip, plus minus facial pain or pressure, plus reduction or loss of smell lasting for more than 12 weeks. And whom do we call as difficult to treat rhinosinusitis? This is defined as patients whose symptoms they persist, and rhinosinusitis, despite being given appropriate medical and surgical treatment. So these patients are called like difficult to treat rhinosinusitis patients. And yeah, why some patients are more refractory than others? As we have learned through a last decade or two, that CRS is not one single disease. There are multiple factors: inflammation, infection, obstruction, so many things, immunologic problems. Phenotypes, CRS might be like with or without polyposis, and there's so many other spectrum of the same disease. There are multiple endotypes. We're still learning more about it. And sometimes the surgery performed in the CRS patient might not be complete or might not be nicely performed, which also causes a failure. And lastly, the outcome expected of the surgery and the treatment by the patient and actual reality might differ, because patients might expect a lot, but ultimately they don't understand that it requires a long-term treatment, a lot of hard work on the patient himself and from us also. So how the things have changed over a decade or two. Initially, it was more of a concept of obstruction and infection, which involved rhinitis, rhinosinusitis, with polyposis or without polyposis. It was the same cause, like was obstruction infection. But as we have learned more and more about it, now we know that CR is mostly inflammation. No longer just a major role of ventilation surgery. There is much more to that than this only. Then more than CRS, with or without polyposis, we have gone beyond that. And there are so many other subtypes. Nowadays, we know that it's mostly inflammatory with a wide variety of genetic and immunologic contributions. So as we see in this diagram, that how things have changed initially, when we started learning about CRS, rhinosinusitis nasal polyposis was almost the same kind of thing, and the underlying cause was mostly given as infection and obstruction. Not saying that it's not still a cause of nasal polyposis, but mostly it has changed from there. And as we learn more and more about the disease process, we realize that inflammation plays a critical role in nasal polyposis. And as of since last 10, 15 years or so, we have realized that inflammation is the major role underlying factor for nasal polyposis. There's inflammation, there's fibrin deposit, and the coagulation, which causes the ultimate end result of polyposis. So in management of inflammatory sinus disease, what are you trying to achieve? As we have discussed earlier also in other programs, that we need to create a single new sinus cavity that helps us to irrigate, that helps us to make the steroid go inside the sinus cavities, which we cannot give by oral or systemic means. As oral or systemic measures, they also cause plethora of side effects and more damage also. So by creating a single new sinus cavity, we can give irrigation, which reaches the depths of our sinuses. We can remove the mucus easily, and we can reduce the mucosal area, so less inflammation, and increase mucociliary clearance also. Just want to talk about a little bit of nasal sprays. Are they really the treatment for sinusitis? I don't think so, because where the nasal spray reaches is, frankly speaking, if we see studies, it hardly reaches the tip of middle turbinate. But we want to reach the reach of the sprays to be in the sinuses, which are way laterally, and nasal sprays they do not reach the sinuses. So giving nasal spray as a treatment for chronic rhinosinusitis is, I don't think so, is justified. So as we start talking about surgery, so this is a simple patient with a osteometal complex blockage, and these symptoms do very well. They do need surgery sometimes. Yeah, after giving maximal medical management, they give us very good results, and simple surgery will cure them almost. And even procedures like which we don't do anymore, maybe like simple sinus wash can be beneficial for these kind of patients. These are easy to treat patients for us, and they give good results also. But this is one particular disease I have mentioned here, like the central compartment atopic disease, which was recently spoken about in the EPOS 2022. This is what some might say as a polyp. It is not a polyp, it's just a polypal change in the middle turbinate, a lot of jelly-like substance which accumulates. And this is not sinus problem. So this is one patient where I not like to operate. These are the things like we have to be very careful. As we correlate in a CT, we can see that mostly the inflammation is around the intercentral cavities. The peripheral rims are all hollow. So this is not actually a sinus disease, mostly because of allergic reaction, inhalant allergies, which causes this kind of infection, and they are mostly relieved by uh, management of the allergic system. So when we talk about sinus diseases, this is a kind of patients which sometimes we do get, as we see in the CT. It's a diffuse CRS, maybe with or without polyposis, it doesn't matter. But these kind of patients do need help. We give them maximal medical management, but ultimately we might need to take up for surgery. And what are the basic things when we go for surgery in these kind of patients, and what are we trying to achieve, what we want to do? We need to know more about it. So in these difficult to treat patients, very nice guideline has come up. I have spoken about this in earlier discussion also. And I think every rhinology person or ENT doctor should go through it. They have classified rhinosinusitis based on primary and secondary. Simple thing like primary is primary. It's not a, there's no secondary cause like a tumor in the nose or maybe cystic fibrosis or a tooth infection causing secondary maxillary sinusitis. So they have divided into localized and diffuse. It's mostly type 2 and non-type 2. I won't go too much in depth of this. These are, I'm talking about all this because they do help us in giving good results to the patient post-surgery, before surgery, and how we counsel them, on how we differentiate which patient will have good results and which will need long-term treatment and maybe supportive treatment from other streams also. So current treatment goals in chronic rhinosinusitis. First, we have to eradicate the bacterial infection. And as already mentioned, we can create a widely open sinus cavity, which is the new sinus cavity where irrigation can reach, steroid irrigation can reach, and which also will help in recovering the mucociliary function. And then we treat the inflammation locally as like avoid systemic therapy. I tell my patients that if I give you a course of steroid, you'll feel better. But then the steroid tablet goes into your stomach, goes into blood, it goes into your bones, brain, kidney, liver, everywhere. And there is no system in the body which doesn't get badly affected by these steroids. So what we do, we create a situation where you can do local irrigation, which will not have the side effects of a systemic therapy. So nowadays, there's a lot of explanation to patients regarding how we are going to look forward to the problem here. Current treatment goal, first of all, we have to acknowledge that is an inflammatory disorder. It's not an obstructive disorder, it's an inflammatory disorder. There's nothing like surgery is better or medical management is better. It just should be tailored and mostly both used in combination. There is none superior. And again, shifting from systemic therapy to local therapy. Simple nasal sprays are not sinus treatment, as I've already discussed. So, in what patients do I go for surgery? When I have chosen that I'm going to operate on a patient, we all discuss it and discuss what is the outcome, what can be the difficulties, and how long it will take. You might need a lifelong follow-up also. My goals when I go to the OT was first to remove the nasal obstruction or congestion, because most of the patients, their primary thing is they come up with, my nose is obstructed. They might have polyposis or diffuse inflammation, whatever it is, they get operated. But the end result they want, that is removal of the nasal obstruction they have. Whatever we do, if the obstruction is not removed, they will not be happy. So second, again, making a new sinus cavity for irrigation. And then after we make a new sinus cavity, we give irrigation, then how to achieve the long-term control of inflammation. Maybe use of steroids post-op also, maybe use of biologics, maybe use of anti-inflammatory other therapies. And if I do operate in a patient with CCAD, mostly I don't operate in CCAD, but sometimes if there's a lot of barotrauma and things, if we do operate and do make a new sinus cavity, I might not achieve cure also. I'm not sure, but if I do, I will be very lucky. Yes, how do you remove the obstruction? First of all, we remove the polyp, but that is not the only thing that we should do. That is not good enough because we have to remove the underlying factors which has caused it in the first place. Yes, septum correction. Any FES I do, if there is a slight deviation in the septum, I absolutely make it a point that I remove it. It hardly takes 10 minutes or so, but the end result is much better. First of all, because it helps in better irrigation, helps us in see the sinus cavities better. Overall result is so much better when I take another 10 minutes just to remove any kind of minor subtle correction. If there is a concha bullosa, it has to be removed. Absolutely, it is a must in sinus surgery. Inferior turbinate, I don't normally touch in sinus surgery. Long-term control after surgery, how do we achieve a long-term control? So it has all changed in the last decade or so, how you used to manage my patients. Now it has changed so much. Initial minimum 30 days to 45 days. I do advise them to take oral or systemic steroids, because even surgery is such a push of the inflammation. There is so much inflammation post-operative period that we need to give them a few days of a window of days that they can we can give them systemic support. Then irrigation starts after around 3 to 4 weeks minimum. We give steroid irrigation with minimal 200 ml high flow devices, minimum 200 ml. Nothing less than that will be beneficial. In non-ECRS, like patients not responding to steroids, a lot of patients they're non-eosinophilic, they have non-eosinophilic CRS. We give them long-term macrolide therapy. Yeah, and this is the biggest change that has come recently. Role of biologics, though not very easily available, and frankly speaking, at this time and date, I don't have much idea about it also. But I have taken help from my pulmonology mate. So we patients who are refractory, post-op refractory, they have a lot of edema in the middle tablet and post-op, a lot of swelling and things. We have now shifted to role of biologics also, if feasible. But definitely with the help of my pulmonology friends. So again, we're coming to CCAD. There's one kind of patients where it is difficult to treat and the outcome expected are very high, but we cannot give them so much. So it's very important we talk to the patients about long-term management. Yeah, it's mostly because of inhalant allergy, and mostly allergy control and biologics might be help. Surgery in case there is severe trauma, and if ever I do surgery, I mean, again, I'm saying the same thing. It is very difficult to achieve a cure. Sometimes, yeah, a few occasions have been lucky that maybe with changing age, their allergy drive has vanished, so they become benefited, and it coincides with the same time when we do the surgery. And these patients are just generally very allergic, and they mostly have childhood asthma also. It's very important that we take a history of childhood asthma in patients we're preparing for tests, because that gives it's a huge indicator for patient having high allergic condition. And suppose we operated. So to achieve all the goals, like for irrigation purpose and things, we need to have a new sinus cavity which looks like this. If it's congested, there is no surgery will end up in failure. And this requires not only nice pre-op planning, proper technique, proper instrumentation. Also, a very important part is a post-op care, where to call the patients on reviews for nose cleaning. Suppose we have done a abdominoplasty or maybe a swell body removal, we might need to put some silastic sheet also for 2 to 3 weeks. A lot of things which goes on, which we decide on the table, and how the best can be done for patients to achieve a end result like this. Since I've been talking about biologics, so when do what is the EPOS guidelines for using biologics? So patients who had already been operated and they have bilateral polyps, three criteria are required. Evidence of type 2 inflammation, tissue eosinophilia more than 10 per high field, or blood eosinophilia more than 150, total Ig more than 100. Need for systemic corticosteroids or contraindication of the systemic steroids, which who require more than 2 courses of steroid per year, and significant impaired quality of life, not 20 to score more than 40. And there is significant loss of smell. Anosmic or smell test may be helpful. And diagnosis of comorbid asthma. In case of asthma, regular need for inhaled corticosteroids is there. If these are the criteria which are met, then we can send the patient for biologic. And yeah, and how is the response defined? It is reduced nasal polyp size and reduced need for systemic oral corticosteroids. There is improved quality of life, improved sense of smell, and there's reduced impact of comorbidities. So we can scale them like good or excellent. 4 to 5 criteria are met, then it's good response. Poor response is just 1 to 3 criteria are met, and low response is 0 criteria. So if these after 6 months we evaluate the response. If red, we discontinue treatment, and if it's red after a year, there's no point carrying on the treatment. Since I've talked about the tests, I just want to add a few things about turbinate and septum surgery here. frankly speaking, doing for surgery for nasal obstruction, random manometry should be gold standard. But since we don't have here, this for the juniors, like how you can choose a good patient for septum and turbinate surgery. Patients who have cyclical nasal blockage, there is side-to-side blockage, one side gets relieved, the other side gets congested. They tend to have very good results with septum and turbinate surgery. Patients who have postural congestion, like venous congestion, when they lie down, they feel it more. And a long-term, very important history patient gives that I get relieved by using oxymetazoline drops or any other something like that. These patients, they tend to fare very well with surgery. But some patients, again, they do have a lot of inflammatory condition, may require immunotherapy also. And one more thing, I have recently started looking for swell bodies in patients who I do septoplasty or maybe turbinoplasty, because it should be removed. Sometimes the swell body is very huge, but the only problem is if we remove a swell body, we need to put a stylistic sheet for quite a few days, maybe uncomfortable for the patient sometimes. And yeah, so maybe 10, 12 years back, things was very different. But as of date now, when do I do surgery? AFRS, absolutely, I take up for surgery. Chronic rhinosinusitis with polyposis, grade 3 and above, I directly mostly take them to surgery after giving a medical management. Fungal ball is an absolute indication, absolutely do surgery. Without polyposis, I again do medical management plus surgery, but we have to keep in mind what are the patient expectations are, and is he willing to carry on the treatment for long duration and do the hard work, and should be aware, because a lot of patients, they initially say, okay, we'll do it, and but they end up lost to follow up, and the results are bad, your name is bad. So whenever I'm thinking I'm planning to do a surgery, surgery is not my end result, not my main target. Surgery is, in fact, is used as a tool to achieve a treatment outcome. Not because patient is highly symptomatic or the patient is really complaining about her disease or his disease, but when I think that it can be done and something I can do a benefit to the patient, then only I can go ahead with it. Obviously, you have to understand that the patient will cooperate. And any surgery, particularly in sinus surgery, I need to have a clear reason why I'm performing surgery and what goal will I achieve by doing this surgery, and particularly in a patient who has a diffuse disease. Uh, I'll be finishing early, I guess. So for new gen ENT surgeons, a few things, as I've always mentioned in all my talks, if I give anywhere, if I meet people also, I just ask them, please do category dissection. It is so important, particularly when you are under an umbrella in a medical college. And at least in your first 8 to 10 years of practice, please try to use 0-degree scopes, because whenever we use angle scope and it's difficult to reach places, it mostly becomes a surgery of struggle and just scrapping through the things. But for that, we can always learn these pre-lacrimal approaches, Denker's approaches. These are not so difficult actually. They might sound difficult, but they are not so difficult. And any FES surgery, we should not leave any areas to heal by secondary intention. Absolutely contraindication. There should not be any raw surface, raw bone, because in our nose, it's almost like 15 to 20,000 liters of air which goes in. It is very difficult for remucosalization in our nose. And learn about post-op care. Learn about post-op care from your seniors. There's so many people who help you out. It is so important. Post-op care it plays a huge role. So with this, I think I have not mentioned about how do I do it. If time permits, then we might go ahead also. But as of now, there's a good saying that I just want to mention here, that if prednisone didn't have any side effects, we didn't have had jobs. Seriously, I mean, it's so true, because CRS with polyposis gets so much managed better with prednisone, but then it has so many side effects that we cannot use it on everybody. So with this, hopefully I've come to the end of a short talk. I have not discussed about the steps of the surgery. I hope like because everybody does it, so common thing. Thank you.
Thank you, Dr.
Manish.
Thank you.
Thank you,
Dr.
Manish. It
Count,
was
please
a nice
give your
presentation.
comments.
Yeah,
It was
thank you, Manish. It was a very nice and lucid presentation that you did. You're known for that anyway. So we have seen you giving lucid presentations over time. Um, I mean, you have touched upon the various aspects of the principles of the sinus face surgery, and you have also talked like to do things should be done. I think as far as the complications in the true sense, you told about what to do about not to prevent complications,
yes.
because as the topic said, we are
Mhm.
to discuss about the principles as well as complications in face.
Okay, sir.
Um, so if today I have to sum up about face in today to 2026, I take a quote given by somebody who says his face in 2026 has become simple in principle, but
Mhm.
it has become brutal in complications, because as more and more people are doing face, you also take complications due to over enthusiasm also.
Mhm.
So I think there are few very important points in FEST that one should remember, is that sometimes you have to make a compromise between completeness and safety. When you're doing a AFRS or you're doing a, say, extensive polyposis, everybody likes to do a very complete job, but a full house face. But if you feel unsafe, I don't think you should proceed to do a very complete job, because safety is much more important than trying to achieve a very anatomically complete job. Then we talk about having 4D scopes, the Rubina cameras, and things like that. But basically, it's your anatomy which is more important, as Manish pointed out about cadaver dissections and trying to get the anatomy in your brain, the 3D anatomy, just as you do in temporal bone sections. We should have the 3D anatomy in your brain. Only then you can actually proceed, because everything will not be in a straight line. So, and regarding confidence and overconfidence, this is also very important. Caution is sometimes very important. And again, it was somebody else's quote which said, I stop when I don't see. Suppose every day it's not a very bloodless surgery day. You may have the patient not well prepared. You could have blood pressure fluctuations, tachycardias, and causing a very bad feel. So when you can't see, you should wait, pack, be patient, but you should not proceed when you do not see things properly. And that is not a situation of weakness. It's a sign of maturity, actually, when you keep on doing things like that. And I think what people can take back from Manisha's talk today is to learn about the red flag signs. I personally feel that your CT scan is something like your consent form. You should actually try to identify the kiros, the skull base, the onodi cell, if it's there, and you should also always try to see the position of the anterior
Okay.
ethmoidal arteries, because these are three things which are always very important. And in face, there are only two things which can cause complications. It's the orbit, the artery as well, but it's mainly the orbit or the CSF. You can injure the orbit and cause a complication. You can injure the skull base and cause a CSF leak. And you see, your surgery may bleed, but you won't get sued because your surgery bled or you had to give a blood transfusion even. But if you do not document what you did, you should always note down everything what has been done very properly, which is one of what I'd like to actually pass on to the junior colleagues, because keeping a record of what has been done is very important. It should not be a OT note of FES done under GA, because a second person who may see the patient maybe after 3 years or 4 years because of a recurrence would also love to see what has been done earlier. That would make things much simpler. Manish has spoken very nicely about the EPOS guidelines, which is extremely, extremely important, especially not only for the seniors, for the practicing ENT doctors, but all youngsters also. You should try to read the EPOS guidelines because it will give you a lot of ideas about what is indicated, what is not indicated. There might people be talking about, I mean, Manuka honey, many things, but you should have your own um, knowledge clear because there are which is recommended, which is not recommended, which has got the highest sort of recommendation, and accordingly you should plan. Because when you listen to so many talks everywhere all around the country, you sometimes get confused that maybe I'm not getting good results because I don't have this particular thing with me. I do not have a drug eluting stent, so I'm not getting good results. That's not the point. So one should read the WIPOS guidelines. So I think before I hand over to the moderators, I'd like to just to check, tell two things for the youngsters, especially that whenever you embark on a face surgery, first thing is to see that you have got the CT and you have seen the landmarks yourself on the CT. Number two, you should have the proper scopes and instruments, especially a ball probe, maybe accurate, whatever fancies you have got, and also something to stop bleeding. And you also should have a backup in the sense you should have a person in your diary, the thing in your mind that whom should I call in case of a problem, the phone a friend person. If you're doing something which you're not doing before, so you should actually have a person in your mind whom you can approach if you have a crisis in your hand. I think with these remarks, I congratulate Manish for his nice presentation, and we can the talk is open for discussion. I hand over to the moderators.
Thank you,
Thanks,
Dr. Gautam. Dr.
very nice
Divan
speaker.
Sharma, Dr. Kipamoy.
Thank you, sir, for your nice comment. And am I audible?
Very much.
Yes.
Okay, okay.
Nivanta, it's mute হয়েছে।
Nibaran sir, please. I will take up the questions first.
Nivanta, unmute করো।
Fukan sir has asked for how to address eosinophilic and neutrophilic conditions. Manish.
So, good evening, sir.
Good
So,
evening.
eosinophilic, nowadays, whenever we operate, it's a post-op diagnosis mostly.
Yeah.
Like, if we, I've asked my pathologist who has been doing for last almost 6-7 years, if there is any eosinophils in the sample, particularly if it's more than 10 per high power field, we go for steroids and things, as we have already discussed. It is very rare that we don't get eosinophils, even
How
if
long,
there is slight
Manish, how long you will continue steroids?
steroids, nasal wash. I mean, the irrigation will be continued. But for initial, as I've already mentioned, the post-op period, I'll at least give for 30 to 45 days, if feasible, of systemic steroids.
No, local wash, how long you will continue?
I'll give for at least. I tell them I'll start with you for a year or so. Then we'll follow up again.
Okay.
But then mostly I'll continue as long as possible, unless and until the cavity looks very stable.
If I can budge in, Kripama.
Yes, sir, please.
Yes, sir.
There was a comment again by some international speaker when this question came out that how long in a CRS with polyposis follow-up, how long steroids? He said, I tell my patients that your steroid spray is the toothpaste for your nose, toothbrush for your nose.
Toothbrush.
So you have to.
It's very similar to asthma and inhaler. Something
For lifelong.
Yeah.
For lifelong.
But then initially we just, if you say that to the patient,
I think this is a good point. Manish has brought it up. Actually, we should all try to get our talk to our pathologist and try to ask them to see the eosinophilic infiltration in the tissues and we should always have a habit of sending all the samples for HPE and also ask them to see it can also become a good thesis subject for any medical college people who are listening to here.
Next question is neutrophil.
Yeah, it is actually not very common to not have any eosinophilic infiltrates in the sample. But these non-eosinophilic patients, they do respond very well to like the macrolides for longer term. Again, a longer term is very subjective here. But at
Yeah.
least sometimes I do give for 3 to 4 months also a low dose clarithromycin, which I have been
Okay.
using for quite some time.
Just a minute, Manish. What is the dose you prefer for this macrolides for long term? Because there are side effects too.
Yes, yes, they are definitely. First,
Hepatic side
initial,
effects.
now first post-op period, maybe like first month or so, 250 BD, then I convert it to once a day for 3 to 4 months. And let's
Is
and we follow up.
is it low dose means 250 or like that?
Yeah, it's because most of the patients they are 50 plus, 50 kgs and above, so fine.
You prefer clarithromycin or azithromycin?
No, I prefer clades for myself.
Okay, fine.
Just by the express,
Just for
nothing more.
just for the benefit of people who may not be quite conversant, here giving clarithromycin in the post-phase patient is not to cure infection. You are
Infection.
giving it to control inflammation. So
Inflammatory.
that is the most important point that you should remember. So that is why the low dose is low. You are giving it in low dose because you are trying to control inflammation. You are trying
Hmm.
to make a control infection.
It has a role of immunomodulation also, I think, no, Manish?
Yes,
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 that is
Very
yes.
correct.
important.
Ah. Now the
And as far
next.
as neutrophilic is concerned, clinically you think about neutrophilic when you have
Yeah.
a greenish or a very thick
Hmm.
pus type of things coming out from the
Yes.
sinuses, and you think it is less eosinophilic, more of a neutrophilic reaction.
Yeah. And these are even pre-operatively, they don't respond very well to steroids. They don't respond
Right.
very well to steroids, and they're not so allergic. And mostly in some say in the old obese ladies, it's more common. A few studies were did reveal that, but I don't know how much it's true. But they are not steroid responders.
Okay.
Right.
Now
Dr. Manish,
Manish.
Yes,
hello.
Next
yes,
coach,
sir.
Dr.
Yes, sir.
Niban Sharma, can you take?
Dr.
Yeah.
Manish,
Yes,
thank
sir.
you for your presentation.
Thank you, sir.
I want to ask what is the most challenging anatomical area you encounter during endoscopic sinus surgery?
So, challenging anatomical area, I see the CT scan, read it properly. Because if I feel that any area is hard to access, I plan my surgery according to it. Like the anterior surface of maxilla, if I have doubt, then I will just go ahead do a prelacrimal approach. And yeah, lateral part of sphenoid in a way pneumatized sphenoid sinus. Then we have to already plan like transmaxillary approach. We like so, yes, the frontal, if laterally placed mass or something is there, then we can think about open frontal trephined surgery also. But otherwise, in the midline, in the sagittal section, like it's mostly it's accessible. According to the CT scan, we have to plan accordingly.
Any
Can I
question?
go? Can I go with the next question?
Any question from audience?
It is the chat. Go to the chat box.
Sir, there is
Someone?
a question. There is a question from SB Fukan sir. Sir is asking IL-4 and IL-13.
Mhm.
Inhibitors can replace FAS when it is available and cheap.
Omalizumab, dupilumab,
Uh,
Dupilumab.
IL-4 and yeah.
It
dupilumab.
is Dupali,
Pallium.
Dupali.
Dupilumab.
Yes, sir. Sir, it's like again, as I've already said, ki medical management and surgical management, they go hand in hand. I won't say we will replace stress because if there is so much of obstruction and things, we have to do the remove the obstruction. So there is proper mucociliary clearance and things. And yes, after some time, we can always take the help of these biologics. But I think still surgery will play a role.
Biologics has a very great role in allergic rhinitis.
Sorry?
So, allergic rhinitis, we have
Yes, sir.
biologics
Yes, sir.
to control.
Mhm.
So, sir has asked for this myeloprotein. Is there any role in central compartment diseases?
Myeloprotein.
Myeloprotein.
Inflammatory, pro-inflammatory release by the neutrophils.
I have no idea, sir. I won't be able to say. But yeah, there is role of biologics in that.
May I ask? May I ask Pukan sir to explain this about
Yes,
this
yes.
myeloprotein? Pukan sir.
Sir,
No, no, I'm in the mobile actually.
No
Hello.
problem.
You
No
can
issue.
say,
No issue. Sorry, we are
yes,
audible.
I didn't get a time. Just today I arrived in Guwahati. Actually, no doubt. Just for academic interest, is
Yes, sir.
Professor
Yes, sir.
Harvez. The CCAD, he has just mentioned in post
Yes.
guideline.
Yes.
There is CCAD. The myeloprotein has a great role. It is, as he has already told that he has got not much role in this surgery and this thing. That, but still, the myeloprotein, Gautam has mentioned about the color of the mucus. I think in details I do not know, but it is mentioned in the book about the myeloprotein. Therefore, I've
Okay.
just asked whether it can be discussed here in this platform.
Okay,
Thank you.
okay, sir. Then sir has asked about skin prick test
hmm.
and sublingual immunotherapy
Yes,
and
yes,
subcutaneous immunotherapy has any role in chronic rhinosinusitis?
yes, definitely it has role in chronic rhinitis. I
Yes,
think
sir.
it's we cannot run away from this. This role of immunotherapy is also very important.
And sir has asked about the color ring in endoscopes and why it is there for PGTs. Just you explain it. Why the color ring is given in the endoscopes?
If we discussed it last time, I've missed it. But anyway, I
Sir
think
is
it's to,
asking.
Sir is asking
I
this.
think I think Gautam sir will be able to.
Sir, Gautam sir.
Mhm.
Dr. Manish.
Yes, sir. Yes,
It's
sir.
for easy
Yes, identification.
it's for
Dr.
easy
Manish.
identification of which
For
angle we are looking at, which degree.
there are three
Yeah,
three
go on.
there are three colors, I think. Yellow, green, and red.
Yes. Yellow is for 70. Uh, I think blue is for 0 degree. No, green is for 0 degree. Blue is
Green
for
is
45.
Green is 0 degree, red
Green is
is
0.
30 degree,
Yeah.
then black is 45 degree,
So 45
and
is red.
blue is your 90 degree. That I am
It
having in our
differs from the different
department.
companies
No,
actually.
it's a standard one.
Yeah,
It's
Different companies has a little different
and
colors.
yellow is 70 degree.
yellow
the,
70.
the
Yeah,
question which is arised, why this is colored?
it is the identification of the
It,
scope.
We can see the mark.
Identification of the scope.
Mhm.
Identification, it is
Actually,
written. So,
Because see
and
one thing,
actually, what happens is actually, let me explain. The point is when you're a single, so you will always plan your surgeries that way. But in a big setup, suppose in ECDRIMS, when you have different surgeons, somebody prefers a 70, somebody prefers a 45, then it becomes easy to identify the scopes because the staff may not be able to tell a scope just by looking at it. But again, the degree is mentioned on the scope itself. Not only the coloring, it's also mentioned. And I do not know of any other reason
I
why the
think
colors
I
are
think
mentioned.
I think it's for the scrub nurse who is assisting
identification
for them.
of the scope, not only for the surgeon, for the other staff also.
Yeah, yeah. Scrubs
Yeah.
nurse,
Acha,
those
I
who are
just want to know one thing. During our PG time, there was no such type of your immunotherapy. Immunotherapy was there, but the thing is that if you go through that in 1995, there is one in Indian Journal of Otolaryngology, Sarmah, and Sardana. They have written a good paper about the installation of 15% of silver nitrate in the nose, right? Installation of 15% of silver nitrate in the nose for allergic rhinitis and chronic rhinosinusitis. So whether this practice, Mukund sir, have you used this one during that time during our PGF, and probably you have done also during your time also. Do you have any expert comment on that? Gautam, you did in GM's
Mhm.
installation of 15% silver nitrate in the nose and this year.
Actually, there is a paper, actually, that is touch in the anterior end of the inferior cabinet. I don't know in that actually
And
we have done in some medical.
corresponding part of the nasal septum at a time, not
Yes,
both
yes.
both sides
And
at a time.
It's
Hello,
like, but it
Sanjay.
gives a good result. Whether subjective or objective, I don't know.
So, whether this practice is going anywhere at present, but it gives a very good result. It gives a very good result.
Yes, that's a good result.
Yes, gold is always gold. I tell you one thing. It is a cheap, but sometimes it is difficult to get 15% silver nitrate. We are getting because of the biochemistry department. You can also get it. It is a very cheap patient. They don't have to have. I one thing I tell that even nowadays, normal in the time of furanculosis of the year, no one knows. The new generation, they don't know ethanol, but it is one of the best treatment. Right? Okay, carry on.
Dr. Manish.
Yes, sir.
Hello. Dr.
Yes,
Manish,
sir.
what
Yes, sir.
strategies do you use to minimize bleeding and maintain surgical orientation?
So it starts from the pre-op period. We start the patient on antibiotics. That's what Janki sir used to do. Sometimes he used to give some beta blocker the previous night also, anti-anxiety medications. And proper pre-op nasal packing with Adrenaline undiluted, if it's not contraindicated by the anesthetist. And the anesthesia, we go for like uh, hypertension and bradycardia, preferably both. But a lot of studies have show that hypertension is not so much required, but bradycardia is definitely important. And as Gautam sir already said, ki whenever we encounter, we need to have patience. Everything actually settles down unless until it's a major arterial bleed. We go slowly, pack the nose. Even in this thing, PJ Wormore's book, it's written that most of the breast surgery, it's in category 3 and 4, in between that, where the bleeding is, there is quite a bleeding in PES. So we cannot run away from the fact that that PES is quite again a bloody surgery. Most of the time we do encounter uncomfortable bleeding, but we have to go through it slowly, do packing, stay in the plane, and be aware where the important vessels they are. Again, CT reading is very important. We don't want to get surprised during a surgery. Suddenly the anterior artery is hanging in between, or the carotid is lying dehiscent in the sphenoid sinus. So we have to be very careful. So it's pre-op planning and intraoperative, like Sir said, to be very, be gentle, and don't need to make very harsh, and don't need to pull the mucosa. Debrider does help. A proper debrider does help.
Have you done any revision tests?
Yes, sir. Many, quite a lot.
I think there is a nice question from Nitesh sir, who has asked about any difference in pediatric nasal polyposis management as compared to adult polyposis, and what are the differential diagnoses that one should keep in mind. It's a linked up question. So I think Manish should take, can I have your comments on that?
Sir, nasal polyposis in children.
Hello, can you hear me?
Hello?
And what is the difference with adult?
Pediatric nasal polyposis as compared
Management.
to adult?
Yeah, first of all, I'll be very careful about diagnosing its nasal polyposis. We have to make sure that it is a nasal polyposis. And underlying, I'll do all the investigations. I'll be very careful. Proper CTE contrast if required. MRI also I'll do. Because sometimes it's mostly inflammatory. Maybe underlying adenoid might be a reason. I have to rule out any kind of nasal mass in a pediatric population. I'll be very careful with it. And I'll try to avoid. First of all, I'll try to avoid. If it's really nasal polyposis, still go with a medical management. If it's causing a lot of obstruction,
the most
then we might
important thing,
consider.
actually, you need to rule out cystic fibrosis.
Yes.
In children, you need to rule out cystic fibrosis when you
Mhm.
see a bilateral nasal polyposis in a child.
Mhm.
Nitesh sir would like to add something?
Sir,
That system is included in EPOS guideline.
sir, this has been a headache for me. Actually, there are some there are some few patients who came with a bilateral nasal polyposis and even unilateral nasal polyposis, but then the mass has come out through the nostril, I mean outside. So there is no way we could, treat it medically. So we go for treating with surgically. But then the problem is there's high chance of recurrence seen in those patients, and we do IgE level, it's normal. We do eosinophil count, it's normal. We do what's that sweat chloride test, it's normal. But then this has been one of the nemesis for me, especially the nasal polyposis in children. This is very tricky when it comes to sinusitis causing even orbital cellulitis, everything in children. We could manage it surgically, very good results, very very good results. But then polyposis in children becomes a headache for us, and we need to look a lot more into it, I think, sir.
Can it be bilateral antagonal polyp?
No, sir, I don't think, because the sphenoid is involved, the frontal is involved, the ethmoid is involved,
That
every
that
part
may,
it is involved.
Nitishwar, that may be because of your inflammatory pulse.
Sir, biopsy always say inflammatory polyp, but
Yeah.
then the eosinophil level is low,
Ah,
it's less than 10 per hyperfil. We have
okay.
seen with the Ig also low. We have the steroid, the response to the steroid is low.
So
In children, we cannot do too much of nasal cleaning because they don't cooperate too much. So what I also do, and I think this also helps me quite a lot, is we pack the nose, the post cavity. We pack the nose with jet form, and then we put this Dextrona injection to shock the gel form, and it fills up the space, and in a way it acts as a steroid eluding stents, same way. So the gel form gets absorbed, the steroid keeps on coming out from that area, but then still once the area, the gel form is over, like maybe down the line like 5 6 months, this there is some recurrence going on, because when we do repeat CT, the recurrence is there. So this area, I need to we need to find certain things in this area.
allergic only.
Okay, thank you, Niteshwar.
There's another
There
interesting
is another
question
question.
by, I see, Akhil Sharma, sir.
Akhil Sharma sir, yeah.
Yes. Have you seen fungal infection due to long-term use of local steroid post-fest?
No, sir. Post-fest, no.
There is one question. Better to consider biologics following recurrent polyposis following FES and failure of medical therapy. Cost is a big
Yes,
factor in biologics.
yes, yes, yes.
Is it
The cost
available
is a
in
big
India?
factor.
Is it available in our setup?
Yes, yes, in Assam also it's
Biologics?
available now.
In Assam?
Omalizumab is available, yeah.
In Assam?
Yes, sir.
Yeah, it is available.
Okay.
Yeah, yeah.
Can you share the details later on?
Omalizumab is available in Dibrugarh as far as I know. And
Yeah,
Dibrugarh.
omalizumab is available.
yeah,
Okay.
Pulmonologists are using it.
they're using it.
Okay. We also need this in future. What about the bleeding during surgery uncontrolled may need to postpone the surgery? Do you have any situation like that? There is excessive bleeding and you postpone the surgery.
Not for face. Generally, it's
Okay.
mostly controlled after packing for 10, maybe 5, 10 minutes. It's generally controlled. Yeah,
Like,
I did postpone one initial
like
case, not
they
fest.
may be asking about the anterethmoidal artery, maybe.
Anterior artery,
Akhil Sharma sir.
yeah, actually, if it's very laterally or very medially injured, then they are high risk. But if it's injured in the midline, it's not much. We can just coagulate with a bipolar. In fact, I have to do it a few times, but nothing catastrophic has happened. Yeah, there's a complication in the book. It can happen with me also, but as of now, till late, God's been very kind and hasn't happened.
Sir has another question. Is it
Yeah,
always necessary to postpone the surgery if there is complication like fat prolapse or CSF rhinorrhea?
CSF rhinorrhea, if the patient is under table under anesthesia, I'll put a flap. I'll put a flap. If I see there is a breach, I'll put a flap immediately. If there is fat prolapse, I'll try to make sure that I don't injure the median rectors. First of all, we have to be very careful. And by the time, if I am like what I do is I try to access the posterior ethmoids mostly after I've already done my sphenoid work. Then after that, I come back and do the posterior ethmoids. Uh, I I don't know if I might stop the surgery, but if there is a definite fat prolapse, I'll be careful and try to manage somehow.
The most important point in fat prolapse is one should be able to recognize it early and
Hmm.
keep your debrider away
Yeah.
immediately. Because
Yeah.
if you still use a debrider when you have fat prolapse, there's every chance that your debrider is going to suck in the fat and suck in the medial rectus as
Medial
well,
rectus.
and you'll have a permanent damage.
Medial
And
rectus is very
similarly,
bad, sir.
recognizing a CSF leak is also very important. Yeah. So you should actually keep away the debrider immediately when you recognize there is a fat prolapse.
Medial rectus injury is very bad.
Yes, it is a very bad sort of injury. Uh,
Nitishore, for the juniors, how will you diagnose CSF leak during the surgery?
Sir, the easiest way to diagnose a CSF leak is when there is a fluid, a clear fluid which is going in between the blood, a clear fluid stream going among or in between the blood. That's the easiest way to diagnose a CSF leak.
But we are using the fluid also for irrigation, for
No, no, no,
uh,
sir. Sir, we have to mop that area either with merocellar or just a gauze and then see. And then see if there is a clear fluid coming down. That is CSF. After mopping. After
I think
mopping away.
Niteshwar is called the washout. I think it's called the washout
Water
sign. I
wash
think
out,
it's
wash
called the
out.
washout sign.
Blood
Washout
wash
sign.
out, something like that.
this is for the
Yes.
PGDs only. Okay.
Mhm. But I
Now,
would say, sir, once you diagnose CSF,
I think
it depends on the person's
uh,
experience to whether to deal with it then and there itself or to take help of somebody. But let's not be heroic about it.
yes.
Okay, Kripamoy, please take the questions. It is already 10 past 9.
Now the next question is mechanism of action of silver nitrate in allergic rhinitis. We already discussed this by our Shubham sir told about that, I think. And next is from sir, do we need to rinse the post face cavity with injection liposomal AMB during follow-up? Liposomal AMB,
Amphotericin B.
Amphotericin. I
Yeah.
amphotericin.
don't know. I don't.
I think
If it is mucormycosis, then it is all right. Otherwise, not.
Mm.
mucormycosis. Yes. Now, Akhil Sharma sir has asked about how do you monitor vision post-operative? Which color blindness occurs first? How do you treat such patients? Which color goes first?
Try to avoid it during surgery. That's the best thing to do. And
Yeah. You are cautious about that, but if it
yeah,
happens, then which color will goes first?
I'll ask my ophthalmologist to see. I'll not be breaking my head over there.
Okay. Then how? I think this is the second last question. Have you ever encountered anterior ethmoidal artery bleeding? How
Yes,
you
yes.
have treated such a case? If the bleeding is intracranial part, how do you manage? Suppose it has retracted into the orbit.
Then obviously we'll. I have encountered bleeding, but it was mostly in the midsection. It gets easily coagulated with a bipolar.
Yeah,
So
Laterally,
Luckily,
suppose it has gone into the orbit.
it hasn't happened till now.
It
Again,
has
then we might need to do.
happened to me. I had done a lateral capsulotomy in one
Canthotomy?
case. Yeah, I had to do a lateral
Sir, your voice is
capsulotomy in
not
one
coming,
Your
sir.
voice is
case.
breaking, sir.
Voice is breaking, sir.
Your net has gone.
Only in one case till now.
Voice is not coming, sir.
I think I said actually
You can stop the video. Yeah.
Yeah, stop the video.
You can take the next question.
Okay, there is a last question from Akhil Sharma, sir. Is FES beneficial if there is associated pulmonary fibrosis?
Pulmonary fibrosis.
Yeah.
But in here, it is beneficial in bronchial asthma. Patients they tend to have good results. I don't know about pulmonary fibrosis.
This pulmonary fibrosis, can this be associated with cystic fibrosis?
Yeah.
So you have to do a complete FES with all this douching and all these things. Sir, Gautam sir, what you are explaining about that?
Lateral canthotomy.
Lateral canthotomy. Yeah.
Yeah. No, that I have only said I have done it in only one case. It a long time back. It happened to me.
We had one case.
I think most important thing in FACE is you have to respect anatomy, you have to respect the complications, and you have to respect your limits. There are three things I always believe in FACE. Respect your limits, respect the anatomy, and respect complications. Then you won't fall into problems.
Sir, if I may add regarding this intraorbital bleeding, just 2 points.
Yeah, sure.
Sir, the first thing is what I would personally do is, since the the sinus cavity is already in front of me, I would do a medial orbital decompression. Medial orbital decompression. I'll tell you the reason. Medial orbital decompression, and then followed by canthotomy. If the pressure still persists, cantholysis. Why medial orbital decompression is because I have to remove the lamina pressure that would again decompress the orbit. And number two, if I make an incision, a horizontal incision in the periorbita, the bleeding inside will now bleed towards the nasal cavity. We should not interfere with the bleeding or try to catch the bleeding point, but rather let it stop by itself by vasoconstriction. It will naturally stop. But that bleeding will now need not cause any increase in pressure in the orbital cavity once you have you cut the periorbita. I think that should be.
We have finished our questions.
Yeah, there is no more.
There is another question Dr. Avinash has asked.
Yeah,
Do you
Avinash
ever
Kumar.
tried FACE in child?
That's only that I try to avoid, because I have to be very sure about what is the underlying condition is causing it. But I try to avoid. And as Dr. Niteshwar already mentioned, it's not an easy thing to do. So let's try and avoid it.
Okay. Now, so we have come to the end of our classroom. So last is vote of thanks. So respected President, distinguished faculty, esteemed experts, moderators, speakers, and dear colleagues, on behalf of the Scientific Committee, NEBOY, I extend our heartfelt gratitude to everyone who contributed to the success of today's 10th NEBOY classroom on principle and complication of the endoscopic ear surgery. We are deeply grateful to Dr. Gautam Khan for gracing this academic session as our expert and for sharing the valuable insight and experiences. We sincerely thank Dr. Manish Kumar Singh for his excellent presentation, which enhanced our understanding of this important topic. Our special thanks to our moderator, Dr. Nivaran Sharma and Dr. Kripamoy Nath for guiding the discussion so effectively. We also thank Dr. Shubhamoy Chakraborty, President NEBOY, and Dr. Anjana Bhuiya, Honorary Secretary NEBOY, for their leadership and support. We appreciate the active participation of all members whose questions and discussions made this session highly interactive and enriching. With this, we conclude today's classroom session. Thank you all for your valuable time and participation. We look forward to meet you again in future academic activities of NEBOY. Thank you and good night. Thank you all.
Thank you.
Thank you, Manish.
so much.
Thank you.
Thank you,
Thank
sir.
you.
This was
Very
so